Welcome back to the deep dive. Today, we are focusing on, well, a few square inches of the human body that frankly seem designed to give surgeons nightmares. It's a piece of anatomy that is visually small, but strategically just massive. We're talking about the thyroid gland.
It really is high-stakes real estate. That is, I think, the best way to describe it.
That phrase jumped right out at me from the source material. High stakes real estate. Because when you look at the anterior neck, you aren't just dealing with a simple hormone factory. It's more like a packed elevator shaft of life support systems, all crammed into this tiny space.
That's the perfect visualization. It's incredibly compact. I mean, within millimeters of this butterfly-shaped gland, you've got the patient's airway, the main blood supply to the brain,
Right.
and, the nerves that control the ability to speak and breathe. One wrong move during surgery or even a missed sign during a routine exam, and you can alter a person's quality of life forever.
And that is exactly our mission for this deep dive. We aren't just going to list parts like a first-year anatomy textbook. We're looking at this through the lens of applied anatomy. We want to unpack how the structure of the thyroid really dictates safety. We're looking for the danger zones, the surgical roadmaps, and those specific exam pearls that trip people up, whether they're medical students or doctors in the clinic.
Exactly. The goal is to move beyond just identifying labels and start understanding the relationships. Because in thyroid surgery, or even just in a physical exam, understanding those 3D relationships is the only thing standing between a successful outcome and, well, a permanent injury.
So let's orient ourselves on the map. If I'm looking at a patient's neck or a scan, where exactly are we planting the flag?
Precision is key here. So the thyroid gland is located in the anterior neck, specifically positioned opposite the vertebrae C5 to T1. It sits right in front of the trachea, just inferior to so, just below the thyroid cartilage.
Which is interesting because I think people often hear thyroid and assume it's wrapped around the thyroid cartilage, but it's actually sitting lower down. It's wrapping the windpipe itself.
Right, it hugs the trachea.
Yeah.
And structurally, you've got two lateral lobes. They're roughly conical in shape. And connecting them is this little bridge called the isthmus.
The isthmus, that sounds like a geographical term.
It is. It bridges the two lobes. And this is our first major clinical landmark. That isthmus usually lies directly over the second, third, and fourth tracheal rings.
Why is that specific numbering 2, 3, and 4 so critical? I mean, why do we need to be that precise?
It's vital for procedures like a tracheostomy. If you're performing a surgical airway, to help someone breathe, you usually go in around the second or third ring. If you don't realize the thyroid isthmus is draped right over that spot, you're going to cut directly into a highly vascular organ.
Which would be a bloody mess.
To put it mildly, you have to know it's there so you can retract it or divide it deliberately. You can't just ignore it.
So the isthmus is basically a do not dig here sign unless you know exactly what you're doing. Now, the sources brought up a structural variant that I found fascinating, the pyramidal lobe. It sounds like something from an adventure movie, but apparently it's a trap for the unwary surgeon.
Oh, it's a classic trap. And it's actually an embryological ghost. To understand it, you have to realize that when you're an embryo, your thyroid actually starts forming at the base of your tongue.
Really? I didn't realize it started that high up.
It does. It starts at the tongue and migrates down the neck through a tube called the thyroglossal duct. Usually that duct just disappears once the thyroid reaches its final destination. But sometimes the bottom part of it persists. That remnant becomes the pyramidal lobe, a finger of thyroid tissue that shoots upwards from the isthmus.
So it's like a trail of breadcrumbs left behind during development.
Exactly. But here's why it matters clinically. Let's say you're doing a total thyroidectomy for Graves' disease or cancer. You remove the two lateral lobes, you remove the isthmus, you think you're done. But if you don't specifically look for that pyramidal lobe and remove it, you've left behind active thyroid tissue.
And if the goal was to remove the disease,
Then the disease recurs. It comes right back in that leftover tissue. It's essentially a job not done. So hunting for that pyramidal lobe is a standard of care.
it's like cleaning up a spill. If you miss a spot, it's just going to spread again. Now, speaking of spotting things, let's talk about the physical exam. There's this moment where the doctor hands you a cup of water and says, okay, swallow for me.
The famous swallow test.
I always just assumed they were checking if my throat hurt, but the notes emphasize there's a purely mechanical reason for this.
This is the aha moment for understanding neck masses. The thyroid gland is unique because it moves with deglutition with swallowing.
And that's because it isn't just floating there, it's anchored.
It's tied down tight. The thyroid is enclosed in a fascia, and specifically, it's anchored to the trachea By a thickening of that fascia called Barry's ligament. Because it's physically tethered to the airway, when the trachea pulls up during a swallow, the thyroid has no choice but to go along for the ride.
So diagnostically, this is huge. You see a lump in the neck. You ask the patient to swallow. If the lump shoots upward,
It's all certainly thyroid related. If
Yeah.
it stays put, it might be a lymph node, a lipoma, something else entirely.
but the source material flags a specific exam trap here. What about sticking out your tongue?
This is a favorite question on medical boards. A thyroglossal cyst, which is a fluid-filled remnant of that duct we talked about, is connected to the base of the tongue. So if you ask the patient to protrude their tongue, that cyst moves up.
Okay, so let's get this straight. Swallow equals thyroid gland movement.
Right.
Tongue out equals thyroglossal cyst movement.
Precisely. Swallow for the gland, tongue for the duct. It's a subtle difference, but it tells you exactly what anatomy is involved before you even order a scan.
I love that. It's leveraging the body's own rigging.
Now, let's peel back the layers. You mentioned fascia, but the notes describe the thyroid as having a fortress of capsules.
It's a double-walled fortress. This is critical for surgery. First, you have the true capital. This is a thin, fibrous layer that just hugs the gland. You can't really peel it off.
Like the skin of a grape.
Good analogy. Then, surrounding that, you have the false capsule. This is formed by that pretracheal fascia. Now, the magic and the danger is in the space between those two walls.
The gap between the true and false capsule, what's hiding in there?
The plumbing, the thyroid vessels, the rich network of arteries and veins are largely located in that plane.
So if you're a surgeon, that gap is your workspace.
It is, but you have to be careful. You need to navigate that specific vascular plane.
And while we're in that space, we run into that anchor, again, Barry's ligament. The outline lists this as a major danger zone. Why is it so dangerous? It's not the ligament itself that hurts you. It's the neighbor. Running specifically very, very close to and sometimes even through Barry's ligament is the recurrent laryngeal nerve.
The RLN, the wire that controls the voice box.
The very same. The RLN is responsible for moving the vocal cords. And because it sits so close to this dense, tough ligament, it's incredibly vulnerable during the final stages of removing the thyroid.
I can just visualize the problem. You're a surgeon, you've freed up most of the gland, but it's still stuck at this one tough point. You have to cut that ligament.
And that is exactly where the nerve is hiding. The source notes a sobering statistic. The majority of injuries to the recurrent laryngeal nerve happen right there at Barry's ligament.
So you can't just pull and cut.
Never. You have to visualize the nerve before you do anything near that ligament. It's the treacherous final mile of the surgery.
It really reinforces that idea anatomy as a map of do not touch zones. Let's talk about the supply lines. The sources describe the thyroid as a thirsty gland.
It's remarkably vascular. For its size, it gets a massive amount of blood flow. In hyperthyroid states, like Graves' disease, you can sometimes even hear a bruit, a whooshing sound, just with a stethoscope on the neck.
That is wild. So stopping the bleeding is priority one. What are the main players?
You've got a four-cornered approach, 2 arteries on the top, 2 on the bottom. The superior thyroid arteries come down from the external carotid. They're the top supply.
And the bottom.
The inferior thyroid arteries. These come from the thyrocervical trunk, which branches off the subclavian artery. They sort of come up from behind the gland.
Okay, so 2 from the roof, 2 from the basement. But the notes mention a wild card, the thyroidema artery.
The renegade.
The renegade artery. Tell us about this one.
The thyroidema is an anatomical variant, maybe in 3% to 10% of people. It doesn't follow the rules. Instead of coming from the sides, it shoots straight up the center of the trachea, usually from the aortic arch or brachiocephalic trunk.
That sounds like high pressure.
It's extremely high pressure. And think back to what we said about a tracheostomy. You're cutting into the trachea right in the midline. If you have a thyroidema artery there and you don't expect it, you could cause a catastrophic hemorrhage in seconds.
Because you're expecting the midline to be relatively safe territory.
Exactly. It's the surprise guest that ruins a party. Always check for a pulse in the suprasternal notch before you cut.
Great clinical pearl. Now, flipping to the veins. The source calls the middle thyroid vein a key landmark. Why that one specifically?
The middle thyroid vein is the surgeon's best friend. It's short, it's stout, and it drains directly sideways into the internal jugular vein.
Why does that make it a friend?
Because finding it and cutting it is the key to opening the door. To see the nerves and the parathyroids behind the thyroid, you need to pull the gland forward and inward. You can't do that if the middle thyroid vein is tethering it to the side.
So it's a retaining strap.
Exactly. Once you ligate and cut the middle thyroid vein, the gland mobilizes. It swings medial and suddenly the posterior space opens up. It's like unlocking a gate.
And once that gate is open, We're looking at the wiring again. We've talked about the recurrent laryngeal nerve, the RLN, but let's dig deeper into voice preservation.
This is arguably the most feared complication for patients, waking up with a changed voice. We have two main nerves to worry about on each side: the recurrent laryngeal nerve and the external branch of the superior laryngeal nerve,
Let's start with the RLN. Why is it called recurrent?
because it loops back. It comes down from the brainstem, goes deep into the chest, loops around a major vessel, and then travels back up the neck to the larynx.
That seems like a very inefficient detour.
It's a famous evolutionary quirk, but the path matters. On the right, it loops under the subclavian artery. On the left, it goes deeper, looping under the arch of the aorta.
So the left one has a longer journey.
Yes, but they both end up running in the tracheoesophageal groove, that little gutter between the windpipe and the food pipe.
And what's its job?
It supplies motor function to almost all the intrinsic muscles of the larynx. Basically, it opens and closes the vocal cords.
And if you cut it,
One cord becomes paralyzed. The patient gets a hoarse, breathy voice. If you cut both, which is a disaster, the cords can flop shut and block the airway. A true medical emergency.
okay, but here's the exam prep the source highlighted. The RLN supplies almost all the muscles. There's one exception.
The cricothyroid muscle. This is the only muscle the RLN does not touch.
So who controls the cricothyroid?
That's the job of the external branch of the superior laryngeal nerve. And this nerve is tricky because it's much smaller, and it runs right along the superior pole of the thyroid.
Wait, isn't that where the superior thyroid artery is?
They're practically holding hands. The nerve runs right alongside the artery.
So here's the setup. You're a surgeon. You need to cut the blood supply to the top. You clamp the superior thyroid artery. If you aren't careful, you clamp the nerve too.
Exactly. And this leads to the golden rule of thyroid surgery. When ligating the superior thyroid artery, you must stay close to the gland.
Why close? Wouldn't you want to be far away?
No, because of the anatomy. The nerve usually diverges away from the artery as they get closer to the gland. Up high, they're together. Down low, on the capsule, they separate. So if you tie the artery high and wide, you snag the nerve. If you tie it low and tight to the capsule, you stave the nerve.
That is applied anatomy in a nutshell. Now, what happens if you miss? If you damage this external branch, does the patient get hoarse?
No, and that's why it's often missed. Their speaking voice might sound fine. But the cricothyroid muscle is responsible for tension. It pulls the cords tight to create high pitch.
It's the tuning peg of the guitar.
Perfect analogy. If you lose that nerve, you lose the ability to tense the cords. The voice becomes monotonous. They get vocal fatigue.
And the source calls this the singer's nerve.
Right. For you or me, maybe it's annoying. For a professional singer or teacher who needs to project their voice, losing that high range is career-ending.
So RLN damage causes hoarseness, but superior laryngeal damage kills the high notes.
Precisely. A subtle but devastating injury.
The stakes just keep getting higher. We've talked about nerves and blood. Now let's talk about the neighbors. The thyroid has some tiny hitchhikers on its back, right?
The parathyroid glands, these are the hidden gems. Usually 4 of them, 2 superior, 2 inferior, and they're generally embedded on the posterior, the back surface of the thyroid.
And we're not talking about big structures here.
No, we're talking about the size of a lentil or a grain of rice. They look like little bits of yellow fat.
Which makes them incredibly hard to distinguish from actual yellow fat.
That is the challenge. The surgeon has to be able to look at a field of yellow tissue and say, that blob is fat, but that blob is a parathyroid.
And why does it matter? If you accidentally take one out, what happens?
It's all about calcium. The parathyroids control the body's calcium levels. If you remove them, or even just damage their delicate blood supply, the patient develops hypocalcemia.
Which looks like what?
It starts with tingling in the lips and fingertips, then muscle cramps. In severe cases, you get tetany and uncontrollable muscle spasms, and even cardiac arrhythmias. It can be life-threatening.
So you take out a thyroid for one problem, and you create a totally different and very serious metabolic problem.
It's a classic surgical complication. That's why post-op, we're obsessively checking calcium levels. It's the canary in the coal mine for parathyroid injury.
Amazing how interconnected this all is. Finally, the source mentioned lymphatics. Why is that included in the anatomy deep dive?
Because of how thyroid cancer behaves. The most common type, papillary thyroid carcinoma, has a very specific spread pattern. It loves the lymphatics.
It prefers the lymph nodes over the bloodstream.
Correct. Papillary goes for the nodes, and it goes to a specific neighborhood first, the the central compartment.
Is that what you call level 6?
Yes, level 6. These are the nodes surrounding the gland itself. Prelaryngeal, pretracheal, and paratracheal.
So if you're treating cancer, you aren't just looking at the butterfly, you're checking the whole garden.
You have to. Knowing that drainage pathway tells the surgeon that simply removing the thyroid might not be enough. They often have to do a central neck dissection, clearing out those level 6 nodes.
Okay, we've covered a massive amount of ground here. The fortress, the renegade, the singer's nerve, the hidden parathyroids. Let's try to synthesize this.
I like to think of it in layers of danger. Anteriorly, you have the approach skin, satisma, strap muscles. That's just labor. Then you hit the vascular layer, the capsule gap. That's plumbing. Then you hit the posterior danger zone,
The back of the gland.
the back. That's where the dragons are. The RLN, the parathyroids, the connection to the airway.
Yeah.
That's where you slow way, way down.
I think that's a perfect way to frame it. Before we wrap, I want to do a rapid-fire review of those exam traps we hit. I'll throw the concept at you. You confirm the reality.
Let's do it.
Trap number 1. A patient has a neck mass. It moves when they stick out their tongue. Is it the thyroid?
No, that is a thyroglossal duct cyst. The thyroid moves when you swallow.
Trap number 2. The recurrent laryngeal nerve supplies all muscles of the larynx.
False. It supplies everything except the cricothyroid.
Trap 3. To save the singer's nerve, the external laryngeal, you should tie the superior artery as far away from the gland as possible.
False. Dangerous. You ligate close to the gland, low and tight, to avoid the nerve.
And finally, Barry's ligament is just a structural support.
Technically true, but practically, it's the ultimate danger zone for RLN injury. Treat it with extreme caution.
So taking a step back, we started this saying anatomy isn't just names on a page. After walking through all this, it feels less like biology and more like air traffic control.
That's a fair comparison, or bomb disposal. The core philosophy here is that anatomy determines safety. You can't be a safe surgeon without respecting these relationships.
It's not about memorizing that the RLN exists. It's about knowing where it is relative to the thing you are about to cut.
Exactly. Whether it's knowing where to tie an artery to save a singer's voice, or knowing to look for that hidden pyramidal lobe to prevent cancer recurrence, it all comes down to the map.
And what stands out to me is the elegance of it. Something as simple as swallowing becomes a diagnostic tool just because of how the fascia is woven. It connects the physics of the body to the practice of medicine.
And that connects to my final thought. We tend to think of anatomy as a static subject, a dead subject. But surgery is anatomy in action. It is a high-pressure application of map reading where the map is made of living, bleeding tissue.
A living map. I like that. Next time you swallow, take a second to appreciate the complex engineering sliding up and down in your neck. Thanks for joining us on this deep dive.
Take care, everyone.